if we could simplify regimens, if we had a way of streamlining and thinking almost like medications as like a personnel roster, and everybody has a role, a defined job. The idea of being able to simplify a regimen is one step closer toward fostering adherence and using medicines that are known to be efficacious as compared to, well, let's add this, let's add this. Patients on multiple antipsychotics as well, which is a very debated issue. We all see these patients, and the literature is not very supportive of efficacy. Now and then a second agent is used for a particular purpose, like for sleep or anxiety, perhaps. But as a foundational treatment, if one is going to use a second-generation antipsychotic, let it be one that has demonstrated value in preventing any phase, any mood episode.
Foundational treatment, that's an interesting term, which is that patients might need different types of medications at different times through the course of the illness, but then there's a foundational treatment. And this is what you're thinking in terms of a long-lasting
potentially
intramuscular.
And a reliable agent. We talk about things like lithium being the gold standard drug. And what we often don't talk about, and people like us have written about this years ago, is lithium works very well for a very small number of people.
If you're fortunate.
If you're fortunate, so who should go on lithium? If you are in that roughly 10% of bipolar patients with pure euphoric manias and family history and so on, for sure. It's just now we're left with 90% of the patients we see that don't fit that profile. So a foundational treatment that has the characteristics of likelihood of response to a certain medication. I don't think we can just say, with all due respect to lithium, I don't think we can say everyone should be on lithium. If you fit the profile, it makes sense. If you don't, what is a more robust potential treatment that will help minimize non-adherence and that can prevent any mood episode? It's a very short list.
But that's why I like the concept of foundational treatment for the non-adherent patient, the long-lasting antipsychotic.
And you made an interesting point, actually, about adherence. One of the prognosticators or complaints about patients why they don't take the medications is the number of medications that they take.
Sure, absolutely.
So this would be a great selling point. We do that very, very commonly with schizophrenia. You have only one injection to take rather than forgetting to take the pill, or somebody's telling you, did you take your medication? You're not doing well because you stopped your medication. Now you don't have to worry about that.
It also must be very demoralizing to patients who come in and say, I'm on X number of pills, and seldom do they come to me and say, I'm on X number of pills, and I feel wonderful because X number of pills is doing such a great job. There's sort of a twofold message of some level of demoralization and despair and dismay that despite all these medicines, I'm still having breaking through of symptoms.
But if I'm, but how much of that is also a provider responsibility? I mean, those patients ended up on these multiple oral medications. It's a course where they ended up. Why has the intervention been delayed? And I think earlier you had asked about what are the the times where we would not use those long-acting injectables. How much of that, outside of these specific cases, is hesitancy? Because if we look at the schizophrenia trials, for example, I mean the John Kane acutely relapsed study, demonstrated that a true oral trial prior to initiating long-acting injectable is probably not necessary in order to see efficacy and safety parameters that are acceptable. Probably, these studies are needed in bipolar disorder as an acute treatment to allow providers and practitioners to think about these agents earlier.